Good afternoon. I hope we're okay to go. I want to welcome everybody to our panel this afternoon on data culture. I have three distinguished panelists with me today. I will allow them to introduce themselves. But when we talk about data culture this afternoon, we're going to talk about a lot of really interesting things, anything from how we develop a culture that encourages data sharing, to how do we make sure that data sharing is possible through standardization, to how do we really ensure that we are developing the kind of culture that uses data in our decision making. So without further ado, I suppose I will turn over to my panelists. I will let them do their introductions. So we'll start with Michelle, and then I'll ask Elise and Peter to introduce themselves.
So thank you, Catherine. My name is Michel Girard. I'm a senior fellow at CIGI, focusing on the linkages between standardization and data governance. I'm really glad to be with you this afternoon.
Elise?
Yes, so I'm Elise Maybe. I'm an independent patient partner, and I have been privileged to be involved on the Pan-Canadian Health Data Strategy as a member of the Expert Advisory Group. So thank you.
Thank you. Peter? Peter, I cannot hear you.
Thank you, Catherine, and hello, everybody. It's a privilege to be with you. My name's Peter Singer. I'm the special advisor to Dr. Tedros, the Director General of the World Health Organization. And on Twitter, I'm at Peter A. Singer, so we'll see you there.
Fantastic. Very delighted to have you here today. So I'm Catherine Burns. I'll be your moderator for the panel. Each of our panelists will give about an 8-minute presentation, and we'll have a bit of a discussion about what does data culture mean. Okay, I'll turn it over to you, Michelle. Could you start us off?
Certainly. Thank you, Catherine. So I hope you'll be able to see my slides during the presentation. So I'll wait for them to be presented here, and off we go. So as you see, I'm going to be talking to you about data governance standards for the healthcare sector, to give you a very high level, very rapid expose as to what's happening in the world of standards to help achieve your objectives. The sources, the presentations will be shared to you if you're interested. The sources are here on this slide. My focus, as I was saying before, is about standards and how can we use standards really to make it happen, to basically resolve those data governance challenges. On this slide here, you're seeing some of the key things that you've already raised. I mean, we need a guidebook, a rules book, in order to address some of these issues. Data governance issues are not unique to the healthcare sector. Data sharing is happening everywhere, and we're facing exactly the same types of issues. We need to worry about ownership of data and copyright. We need to track data. We need to make sure that, you know, we store the data in a jurisdiction that is reasonable to us. I mean, the list is here. It matches with what you mentioned yesterday. That's the reason why I'm saying to you, you will need a common rules book that can be applied across organizations sharing data in order for data sharing to succeed. Going at the speed of light here, this slide shows you what standards are. You are a beneficiary of standards and certification, and probably are not really aware of it, but standards, you know, make the world go around when it comes to products. It allows for products to be safe. It allows for them to be secure, mass-produced, interoperability. We use millions of standards for things that we use every day, from your toaster and your electrical products and water heaters to your Wi-Fi, and the more, you know, sophisticated technologies that are being deployed on a daily basis. Standards allow for establishing some rules, also allow for certifying, you know, making sure and testing, making sure that the products that you're using are actually meeting standards. And one important thing is that standards are incorporated in thousands of regulations. They are a mechanism for compliance. They're not only there on the voluntary side. Sometimes governments use them to ensure that industry complies. So we can do the same with intangible products and intangible services. And data sharing is part of this huge trend of digital transformation. We need standards for data sharing. Let's go to the next slide. Now, it is a huge issue for a lot of organizations. This slide shows you a portion of the 200 or plus organizations that are currently developing what we're calling digital governance standards around the world. There are many international organizations, but right in the middle of this slide, you'll see a little red contour, which is the CIO Strategy Council, the Chief Information Officer Strategy Council. That's a Canadian-based organization that is currently developing a suite of digital governance standards, and I'm going to tell you a little bit more about it because it will directly affect you and impact you in your work if you are interested in participating in data sharing activities. Let's go to the next one. There will be a need for many different types of standards if we want to successfully achieve data sharing across organizations. We will need to speak the same terms. We're going to need a lexicon of terms, you know, patient care, patient-centric care, data, records, are all terms that need to be defined properly, and people need to be on the same page when it comes to the terminology that we use. We will need standards for establishing the right processes. We will need standards to test whether our processes are working properly. And there's no way out of this. This is a complex and controversial issue. If it's not dealt with properly, there will be problems. And there will be a lot of resistance to get into data sharing. So we will need different types of standards to manage all of these issues that are associated with data sharing. Next one. Now, we're not starting from scratch. As I was mentioning before on my slide with all of those logos, there are international and national organizations working on standards. Here, IEEE, has been working now for the past 3 years on a series of standards, which is called an Ethically Aligned Design Initiative. And they're designing standards right now, dealing with privacy, dealing with addressing the ethical issues in technologies and systems. So that organization is very active. And I think that some of the standards, as they get published, could be used as the starting point for the healthcare sector in basically designing, adapting its own rule book for ensuring that data sharing takes place. So there's work being done. That work is available, and it is going to be useful as you start thinking about this rule book that you need to put together. Let's go to the next one. Now, in Canada, we're lucky because we have created in 2018 an organization which is called the Chief Information Officer Strategy Council, CIO Strategy Council. This organization has been accredited by the Standards Council of Canada to develop national standards in this country for digital governance. That's the only focus of the organization when it comes to standards setting. And the standards development process here is open and transparent. It's an online platform. Anybody can join. So CIO Strategy Council wants to include patients, clients, practitioners, experts, industry, and regulators in developing a suite of digital governance standards so that we can establish the rules that kind of reflect Canadian values and reflect the objectives that we need to reach for the system to work. So objectives like privacy, objectives like fairness and equity, are subjective values, but they're important for Canadians, to Canadians. So that's why our digital governance standards need to address the concerns that people have raised, need to set the right systems so that these values are being met whenever we get involved in data sharing. Next one. These are the names of the technical committees that are active at the CIO Strategy Council. So the list is getting longer. We have a committee on data governance. We have a committee on artificial intelligence ethics. We have one on personnel, so the personnel, the certification and the the competencies of these new categories of professional classes doing work in AI and machine learning need to be defined. We have a series of standards on digital identity. This is very important for your sector, so you're going to be interested in this, in addition to cybersecurity, and then when it comes to more tangible applications, sustainable cities, connected cities, and then vehicles. So there's a big list here. On this slide, I'm presenting to you 4 items that would be relevant to the healthcare sector. So it's pretty small on the slide here, but it's dealing with cybersecurity, for example, for the healthcare sector. This committee is going to be starting its work very soon. The sponsors of this include an organization called Healthcare Can. They are connected with the CIO Strategy Council to figure out what would be the best approach to establish some foundational work in terms of cyber for the healthcare sector. Obviously, the standards on digital identity will be of interest to you as well. And there's more coming too. So clearly, there is work that would be of interest to you. That work is starting. We need people to get involved so that all of the various perspectives are reflected. So going to my last slide, as I said, the presentation will be shared. You will have a copy of the URL for the CIO Strategy Council. I invite you to consider, if you're interested in data sharing, if you're interested in setting the rules when it comes to, the future architecture for data sharing for your sector, I encourage you to consider becoming a member of one of the technical committees. It does not require technical expertise. It requires passion and interest in discussing concepts with people. These are new concepts. How do we manage, to put a box that we feel comfortable with when it comes to values, such as fairness and objectivity when it comes to, various groups and privacy. This is brand new. It needs to be standardized. We need that new rules book. And with your help, we'll be able to design something that is world-class. Thank you very much. And looking forward to discuss with you further this afternoon.
Perfect. Thank you so much, Michel. A great presentation. Standardization is really the foundation, right, before we can move forward with any of this, and a call to action. So I hope our audience was looking for that. I'm going to turn it over now to you, Elise. Please go ahead.
Okay, thank you. I'll share my screen. And there. Okay, can you see it?
Yes.
Excellent, thank you. Okay, so thank you very much for the opportunity to speak with you today. I'd like to start with an introduction to myself briefly. So my background is in technology, but I'm also, as a patient partner, very involved in digital health. So that's one aspect of my experience. The second aspect is that I have many relationships and engagements and have done in the health system since 2011, and of course, my patient experience. So I'd like to start with some thoughts about the public's experience of health data and data sharing that form three of my main observations about our current culture of data sharing. To start with, we want to be seen and treated as a whole person, not body parts. And that's not me, by the way. I'm one person, but my data is all over the place. So why is that? Basically, we have a provider-centric health data system, one that's defined by the publicly funded system. And this is not centered around the patient. All the efforts we're trying to make for patient-centered care fly in the face of a system that's not designed for that. So for example, my family doctor can't see any information from my massage therapist. And when we think about the primary care providers who are trying to solve health issues, they don't necessarily have sufficient or complete data to help them do so. So no wonder they're stressed. My first observation then is that most of us want one place for our data. In effect, we want one record or one view of our data that represents us. We want one portal, not one per provider with different logins, different information, and different formats. I have 4 or 5 of them, for example. Currently, the onus is on us as patients to stitch together our information so that we can figure out what's going on. We would really like the system to take over that job for us. Most of us want our data shared with our care team. We already share our data manually, carting it around on our phones or by lugging binders worth of information from clinic to clinic. Right now, it is on the patient and the caregiver to collate and share their data. I mean, really? What if I'm severely ill? What if I don't speak English? What if I'm homeless? What if I go from job to job? How can I do this? This situation actually bakes in inequity into our system. And for clinicians who need to go from place to place to access information, that time would then be better served serving me. And they might be less stressed, which is also better for me as a patient. So take the burden off the data sharing from us and let the system do it for us. Currently, our data is dammed up and doesn't flow easily in a timely or complete manner from care site to care site. For example, there are cases of people who are discharged from hospital to long-term care, but their information doesn't come with them until sometimes days or even weeks later. So the hospital may have changed the prescription, but the long-term care doesn't know that, so they give the old drugs. And that sometimes is very disastrous for the patient. And this happens between care sites, whether it's the home care or whether it's rehab or whatever. The other place where data needs to flow is some people in Canada receive their health services in more than one jurisdiction. So if we think of Ottawa-Gatineau, for instance, or people from Manitoba who might go to Thunder Bay, or better yet, the people in the north who need to receive services in other parts of Canada in the south, so they go to Ottawa or Vancouver or Calgary. If data doesn't flow easily with us, isn't that a safety issue? Now let's talk privacy, or who decides who sees what. Many in the public are really not that clear about the difference between security and privacy. Many of us confuse the two and think about security if we're asked about privacy and whether it's important. Now, we all hope, of course, that our systems aren't going to be, our systems will be secure from hackers. But privacy governs who sees what, and that's a bit of a different issue. Most of us are really not aware that the health data privacy is actually controlled by custodians who conjures up images of jailers, if you will. For some reason, we fret a great deal about privacy breaches, which can indeed cause harm like job loss, but most often cause unease and inconvenience, like receiving ads for diapers after giving birth. As a health system, we don't think about harms from not sharing data, and this seesaw needs to be rebalanced. So my second observation is that the lack of data sharing is harmful. It is a safety issue. Patients experience risks from not sharing data, including death. Frequently, patient partners are driven to do the work that we do because of harms to ourselves or our loved ones. And those harms can come also from these systemic issues of the lack of data sharing at critical points between providers, between silos of care, between jurisdictions, and with patients and caregivers. Clinicians need accurate, complete, and timely data to treat us, or they may inadvertently cause us harm. If we don't do this, this is both dumb and dangerous, and it's harmful to patients. My third observation is that most of us want to share our data for the greater good. Many of us assume anyway that our anonymized collected data is already going to the system for system planning and population health management. And many of us willingly sign consent forms to share our data for research. Where this becomes sticky is when there is a third-party private sector player involved. And this raises the concern that most of us have, which is we don't want our data sold for profit. This needs to be addressed with appropriate legislation protections, and it needs to be transparent to the public. We want to share, so just make it easy and protected for us to do so. So I'd like to close by looking at how COVID has changed how we experience health data. We've just undergone a 2-year crash course in health data for managing the pandemic. We have a heightened awareness as the public of public health and how decisions are made for our communities based on health data, or not. While some may stick their heads in the sand, most of us are aware of case counts, hospitalization rates, vaccine rates, and the like. We have learned that science does not have all the answers and that new knowledge changes the rules, like it or not. We have also seen knowledge gaps and inconsistencies. So how is COVID death actually defined and counted? Why can't we have an accurate case count in our province or for our country? As a community, we are more acutely aware of uncertainties of a pandemic, of the inadequacies of our system, of how our healthcare is stressed and perhaps broken, of a sense that we can't keep going with the status quo. Even with competing crises like the war in Ukraine, climate change, and our personal challenges, we do have an opportunity for change here. So my last observation is, let's take advantage of the opportunity that chaos and crises brings. Let's take advantage of it. Let's rethink and not rejig our health data system. Thank you.
Perfect. Thank you so much, Elise. I really love how you brought a person-centered view into it. I think we've all been patients or clients of our healthcare system. I can see from our participant list, we have a lot of representatives of people who actually work within our healthcare system. I think there's going to be a lot of resonance with your message today. Peter, I'm going to turn it over to you now.
Thank you very much. It's great to be here. It's great to see old friends. I see Vivek and Rohinton, David Castle, and many others in the audience. So very, very pleased to be here. The story I want to tell is actually one of data culture in an organization. And so I'm going to tell a bit of a case study. And that case study, that organization is the World Health Organization, which of course is the Secretariat, folks like me, and member states. And what I wanted to say was that that this case study, I think, well illustrates how a culture of data for decision making can be built. And I hope you will find it of interest. The starting point is, I know there's a lot of students, I know there's a lot of young people on the audience here, and I'll come back to you at the end in terms of some advice and where this all leads from a data standpoint. The foundation for the case study and the story is WHO's data principles, and I put the link to those principles in the chat, so I won't belabor them, but I will just briefly list them now. They are that WHO shall treat data as a public good. WHO shall uphold member states' trust in data. WHO shall support member states' data and health information system capacity. WHO shall be a responsible manager and steward of data, and WHO will strive to fill public health data gaps. And so against that background, let me tell you a story of what started in 2017. In 2017, Dr. Tedros started at WHO, and there was a strategy that was still a year or two left to go, but it wasn't highly measurable, it wasn't highly data-based, it wasn't very intensive on data, even though data is the lifeblood of WHO and of many member states. And so we set about developing a new strategy that's called the General Program of Work, and this was the GPW 13. And essentially our starting point was this: look, there's 50 or so health-related SDG, Sustainable Development Goal indicators, out of the 170-something indicators that there are. About 2/3 of those were within SDG 3, which is the one on health. But about 1/3 were outside of SDG 3, the things that are outside the health system but affect health, water and sanitation, for example. And what we did was we realized that nobody could remember 50 things. And so we boiled those 50 things down into 3 ideas. Universal health coverage, which of course is itself an SDG indicator. That's about access to essential services without financial hardship. Healthier populations, which clusters all those things outside of SDG 3, and preparedness for health emergencies. And this was pre-COVID. We saw that the SDGs were actually inadequate in relationship to preparedness. There was only one little enabling indicator on international health regulation capacities. And so we gave that more prominence. And so the first point I want to make in the story is that data and indicators are central to the strategy, so the strategy is measurable. And not only that, but on the organizational side, Dr. Tedros created an Assistant Director General position for data and delivery for impact, and that's filled by Dr. Samira Asma. So point one is the strategy has data at its heart. And some of you will remember the 3x5 initiative of WHO related to HIV. This is 3x5 writ large across every activity of the organization. The second step then was not only to have measurable outcomes in the organization to create the culture, but actually to measure and report on them. So I can tell you, for instance, today, as a result of WHO's annual results reporting, that on those 3 so-called triple billion indicators, because we set targets of 1 billion more people receiving universal health coverage, 1 billion more people leading healthier lives, and 1 billion more people better prepared for health emergencies. Against those targets and how they relate to the SDGs, because they're highly SDG based, the rate of progress of the world projected out to 2023, because the strategy was between 2018 and 2023, is about 1/3 of what it needs to be to reach the SDGs by 2030. And moreover, on an acceleration scenario, mapping out, well, what happened if you actually did meet the SDGs and sped up, and how could you do that realistically? By about 2025, we can maybe close that 2/3 gap by maybe a half. So firstly, not only did we set out to put measurable goals in the strategy, we also came up with a measurement framework to measure it and measured it. And by the way, that measurement framework teases apart the SDG indicators, which of course are responsibilities of governments, and the work of the Secretariat. We use a balanced scorecard approach to tease out, if you will, the outputs of the Secretariat in supporting member states. And it also uses a multi-method approach, because the dirty underbelly of these things, of course, is contribution versus attribution, which is really best described in qualitative case studies that can link the activities of an organization to actually the impacts that it seeks. So we had measurable goals, we measured them and reported on them. And then the issue becomes, how do you turn those measurements into decisions? How do you close that gap? And here we imported some wisdom from delivery, or deliverology, if you will, started to think of ways internal to the organization where we can do acceleration scenarios, where we can allocate budget against these important indicators, where we can make sure that we know what countries to focus on for each that will accelerate progress the most, where we know what actual delivery strategies we want to use. For example, supporting a country to have eliminate trans fat or taxes on sugar sweetened beverages, et cetera. And then most importantly on execution, to be able to track, follow, look for being off track and do mid-course corrections and bring the leadership in to help with that. So not only did we set measurable targets across all the organization, not only did we develop a measurement framework and report on those targets, we also paid a lot of attention, and this is where we're at now, into thinking about how that data turns into activities in the organization. And then finally, what we realized was, and I think this is probably a common finding, headquarters always wants to talk about indicators, and I think this is the case in any organization. People in countries always want to talk about data and data systems. And so we developed the data principles that I mentioned, but also the SCORE technical package, which is like an X-ray of data systems, and not just in health, but including the national statistical offices, et cetera, in countries, to see where the strengths were, the deficiencies were, and then developed ways to strengthen those. So that's a little case study that should show how WHO is transforming itself into a highly results-based organization, highly impact-focused. Measurable impact are the two most important words in its strategy, but also focused on executing on that strategy. And the foundations have been laid. We continue to double down on those foundations to make sure that we can accelerate and help countries really to accelerate the sustainable development goals, because we're way behind and we need to be much more focused to catch up, and data drives that strategy. And that's why WHO is there to help member states to reach their goals. And with that, I want to turn to my conclusion, which is really aimed at young people. In this process of data-driven strategy, sustainable development goals, indicator by indicator, index by index, and how progress can be accelerated, there's much in terms of lagging indicators, as I mentioned, and that gives young people who are data-oriented the opportunity to find a problem and solve it. Find a problem and solve it. And that's my top advice to you. Use the skills that you have in data science to find a focused problem and to solve it. And it can very well be a problem in data science, and in that way you will help your university, your community, your country, and the world to accelerate progress where we were behind before COVID. We're much further behind now, for example, on universal health coverage. And make the world a better place. So I'll stop there. Thank you so much for your attention. And I wanted to use this as a case study, tell a little story to illustrate just how vital data is. I was an innovation person before I went to WHO, and Rohinton continuously told me about the importance of data. And it wasn't until I got to WHO and experienced the story I told that I finally realized how right he was. So thank you, and that's just concurring with the points that my friend Richard Gould made earlier in his introduction of Rohinton. Thank you, and back to you, Catherine.
Great, thank you, Peter. I would like all my panelists to come on screen for the next part. Thank you, Elise. So we'll just wait, give a second for Michelle. Michelle is here. Fantastic. So as we get going, I think one of the things I want to say is I love the design of this panel because you're all coming at the problem from really different perspectives, okay, and from different stages and parts of our healthcare system, okay, and I thought that was really fascinating. So while the audience warms up, okay, and get some questions into the system, I've got a couple prepped for you, as any good moderator would have. So my first question, I'm going to ask all of you to respond to this, okay, and I admit this is coming out of my own interest a little bit, is once we get the data, we also have to get people to believe in data-driven decision-making. Okay, so how do we work towards that kind of culture that values data-driven decision-making? And if you don't think we're there yet, what are the challenges? What do we need to fix? You know, and I gotta think, just to go back to kind of some of Elise's comments, we saw it with COVID, right? We've got a lot of data coming up. We also have a lot of powerful anecdote, right? And we saw a battle kind of in people's minds on decision-making there. I'm obviously on the data-driven side, but I'd like to hear all three of you weigh in on this. I'm going to ask maybe Elise to talk first, and I'll rotate to Michelle, and then to you, Peter.
Okay, thanks, Catherine. I mean, that really is quite a question. So I mean, I do think that it's up to the public to sort of signal that they want data-driven decision-making. But for the public to be ready to do that, they need to have some level of data literacy to understand the importance of it. And so I think there needs to be some efforts to bring people up to speed in terms of literacy, starting really in kindergarten and going through the population as we know it now. That I think that would be really important to have. Then there's also, like, when I look at the people around me, there's a real desire to have the pandemic be over, as we know. And one can't just decree a over, unfortunately. And so a lot of the governments have gone to just decreeing it's over and stopping with their provision of data and analysis. And they've left it to the public to sort of struggle on their own. And most people who have school-aged children, of course, really feel that. It's a real experiment in public health decision-making that we're going through. And this is exacerbated because the governments have also choked off the source of trusted data. And so they've made it difficult for those of us as individuals to even make decisions. You know, that's really damaged the public trust, I think, in a very big way. So I'm going to leave it there, but I think there's a lot of education opportunities. And I think because of COVID, people see the more importance of health data as a decision-making tool.
I love those points, especially the thought of bringing data literacy into our educational system at a young age, right? I mean, that ties with Peter's quest to bring young people in. And yeah, I love some of the thoughts you bring forward there. Michelle, how would you weigh in on that? What do you think we need to do to?
Well, I think data literacy is important, not only for the users, but also for those who are going to be building, you know, those data sharing networks. So in terms of the principles that I think you need to remember, there are two very important ones. The first one is transparency. And with transparency, you'll get trust. If you have those two, then you're good to go. Now, I think, you know, we need to recognize, though, that when it comes to, you know, making decisions or helping experts make decisions with data, with automated systems, you need to think about your data value chains. So you're going to get a whole bunch of people collecting data that may have nothing to do with the problem you're trying to solve at some other end. So when you think about transparency, you need to be able to categorize your data that you're collecting very well so that people understand, you know, the features of your data, so that they understand what they're getting into by using those data sets. So data collection, transparency is very important. The second part of data value chains is access. To get to the proper sharing, you need to make sure that only the right people with the right credentials have access to the right data at the right time. There's a lot of rights here, but it's kind of a principle that you need to apply so that you don't have to worry every step of the way. Oh my God, privacy. Oh my God, ethics. If you control data access properly, these questions are going to be set aside. They're going to be dealt with only once at the right time. And then downstream, you have the analytics. If you have an algorithm, you want to make sure that there are no prejudices baked in your algorithm that's going to make a whole bunch of mistakes and create some unfair situations down the road. So again, you will need transparency there in order to establish trustworthiness. But my advice to you is as you resolve your problems, look at your data value chains, focus on the right issues at the right time so that you don't have to, basically reinvent the wheel at the right every time, and get to trust and make transparency as a default for all of these things to work. Long answer to a short question, but it's a big question too, right?
That's great. I think I asked a good question. Love the concept of transparency. I'm seeing it popping up in our comments as well. I also really think that tied in a lot with some of the points in Elisa's presentation, right? Even from the patient or person-centered view, right? How do you balance security and privacy? Who knows your records? You want to share your information with the people who can help you, right? Yeah, so I really love that theme that you brought up there. Peter, how would you weigh in on this?
Well, thank you very much, Catherine. I mean, first, just to quickly respond to Alice and what she had to say about the pandemic being over. I just fully agree with her. I mean, to channel Lenny Kravitz, it ain't over till it's over. And it definitely ain't over. And sometimes deeming it over is just a way to disempower the most vulnerable. So that leads me to the point that inherent in the SDGs and inherent in our data exercises has to be disaggregated data, which is such a strong tool to explore equity. And there's a fantastic COVID case study that was written up by Kwame McKenzie about how the Black community in Toronto pushed for disaggregated data, showed the big discrepancies, and then took measures through community mobilization to decrease the discrepancies and inequities in various indicators. I couldn't avoid the pandemic opportunity, but to get to your question, Catherine, very quickly, I mean, it's really just one point, I think, in terms of turning data into decisions. Once you've got the type of story that I described, to sustain it, what you need is to embed that story into governance and into management. And it's as simple as that. So if at every board meeting, your governance is asking management for progress on the $3 billion, what are the gaps? How do you plan to close those gaps? Where are you off course? That's the way to sustain it in terms of governance. And on the management side, if you've got a leader like Dr. Tedros, who is continuously emphasizing equity, but also continuously emphasizing these $3 billion targets, UHC, healthier populations, and health emergencies and the measurements on them. And also if you have champions at the country level, and in our case, it's the WHO representatives, because they can come forward with concrete examples of how data leads to success, leads to improvement on indicators, leads to improvement in people's lives, and success breeds success. And so, like in innovation, data is a very abstract concept until it's not, until it comes alive and you can tell a story of an individual person who benefited from your data activities and all the great standards and everything else that we've been talking about on the panel. And that's the point at which you're creating a recurrent cycle, a positive cycle. So I'll stop there. I know we're short of time, and thanks, Catherine, for the opportunity to be with you and with these old friends and with this great panel.
Yeah, I'm going to challenge. I don't know if it's as simple as you made it sound, but I love your idea that success builds success. And I think that's something we need to start capturing, are those success stories. I've been told I can go over a minute or so, that they won't kick us out. So I'm wondering if anybody wanted to do a quick answer to one of our audience questions in the chat. I've got one on how do we remain transparent, but also limit access? What's the balance? And a second one, saying that sometimes decisions on stats are not always trusted. And maybe this is also an issue on data literacy as well, right? Yeah. Does anybody want to? At least I saw you nodding on that last one. Do you want to make a quick comment?
Well, I was just going to go back to the first one. How do you remain transparent, but also limit access? Certainly on the part of patients and caregivers, I don't think access should be limited to their data. And so I wanted to take the opportunity for that, from that question, to make that comment. We have still a somewhat paternalistic system in which doctors feel they have to make the decision on behalf of the patients. But then patients can also choose to whether they want to look at the data or not. And very often maybe the patient doesn't want to, but their caregivers do because they want to understand what's going on. So I think data access needs to be very readily available to patients and their caregivers. And I'm just taking the excuse to make that point. Thank you.
Perfect. No, I think we're about 2 minutes over. This has gone way too quickly. I think we really could have had a much richer discussion, but I really enjoyed the discussion that we've had today. And I think we are, at least it is the start in the conversation, right? Okay, so I'm going to thank you very much for joining us today. And my understanding is that there's now a break for the audience. So thank you very much, everybody.
Thank you.
Okay.